All right, so reflux disease, remember that the factors in pathogenesis include defective or transient relaxation of the lower esophageal sphincter. Oftentimes patients will have a hiatal hernia, having that part of the stomach up in the chest where there's typically negative pressure sort of makes you reflux more. They'll have poor esophageal clearance. Delayed gastric emptying can often play a role, but not always, but should be thought about in your patients who are not really responding to traditional acid reflux therapy. And then remember what I said about board exam questions being clicky? Man, don't I wish I had written this up in New England Journal so that fat people get more heartburn? I never would have suspected it. I have an idea for another manuscript, and if anyone wants to help me with it, we can do it together. It's basically going to be patients with an elevated BMI tend to get short of breath while walking up flights of stairs. I'd be happy to serve personally as a case report. We can collect some other people. All right, transient LES relaxation. So this is one of the mechanisms. I think we used to say this was the main mechanism. It's not. I don't really think we all think of it as the main mechanism. I think it's just one of the players. But you get these transient relaxations, and then that helps acid get up into the esophagus. And so if you think about this is the diaphragm here, and you have a little hiatal hernia. That negative pressure inside the hiatal hernia when you inhale helps the stuff get up here. Does that make sense? But patients tend to be obsessed about their hiatal hernias. All right, so gastroesophageal reflux disease, the symptoms, typical heartburn, atypical chest pain. I'm actually going to change this slide. This whole thing about hoarseness and sore throat and chronic cough. So the nocturnal cough, yes, absolutely. Patients who wake up in the middle of the night with reflux and cough, yes. This whole thing about hoarseness and sore throat and chronic cough is becoming more and more controversial. And I think reflux is sort of an innocent bystander in asthma. So I think that these things, there was a point in time where these were likely board things. I think that they've become more and more controversial, and they're less and less likely to be on the boards. So kind of keep them in the back of your mind, but I wouldn't spend too much time delving into them. All right, so when you think about GERD, is it simple or complicated? Are the symptoms typical or atypical? Are there any alarm symptoms? If it's simple, typical reflux and no alarm symptoms, then treat the patient with a PPI. So for some reason, I'm frequently sent 25-year-old mildly overweight people with typical reflux, no family history of anything, no dysphagia, and their primary care doctor wants them to get an EGD. So that's a great example of a patient.